Welcome to the Sound of Ideas from IdeaStream Public Media. I'm Stephanie Haney. Thank you for being with us. Recently, celebrities have been more outspoken about their experiences with the M word, menopause, the point in life when women stop getting their periods, bringing up some of the good, but also some of the bad and uncomfortable and really bad things about this life stage. While Tracy Ellis Ross said, "I'm the sexiest I've ever been, and when I say that, I mean I feel the most myself," Gwyneth Paltrow said she would all of a sudden become furious for no reason and that she could feel the hormonal shifts happening in her body. Naomi Watts described early menopause this way: "I'd wake up in the middle of the night drenched in sweat. My skin was dry and itchy. My hormones were all over the place. I remember feeling so confused and alone, like I didn't have control over my own body." She said there was not a lot of support for her at the time and that there's a, quote, "unwritten code of silence. Women should suck it up and cope because that's how generations past have done it." Then, last month, the Food and Drug Administration removed the most serious warnings from hormone drugs used to treat menopause symptoms. These so-called black box warnings stated possible risks from cancer to dementia. Doctors and patients fought for years to remove these warnings that they said were not supported by science. Today, we'll talk to doctors and a patient about menopause and perimenopause, which is loosely defined as the 10-year period preceding menopause. We'll discuss misconceptions, stigma, and new access to treatment for millions of women going through this life stage. Joining me in studio, we have Dr. Rachel Pope, an OBGYN and the chief of female sexual health at University Hospitals, who co-authored a study on estrogen and perimenopause. Dr. Pope, thanks for joining us.
Thank you so much for having me.
We also have Julianne Sutton, who is one of Dr. Pope's patients, who will be sharing her experience. Julianne, thanks for coming in.
Thank you. Good morning.
Later in the show, we'll hear from a clinical psychologist who helps women navigate the mental and emotional changes of menopause and perimenopause. Now, if you would like to ask questions or share your experience with menopause or perimenopause, you can do that by giving us a call. The number to do that is 866-578-0903. You can also send us an email at soi@ideastream.org, or you can send us a message on Instagram at The Sound of Ideas. As we get into this, Dr. Pope, let's start with the medical definition of menopause. When does it happen and what are some of the symptoms?
Sure. That's a great place to start. So the average age of menopause is between age 51 and 52. And so perimenopause can start up to 10 years before that. And what I want people to remember is that these are averages. So I do have patients who go through menopause at 48 and perimenopause might start for them around 38, or they might go through menopause closer to 56, 57, and perimenopause doesn't start till about 10 years before that.
Okay. Can you break down for us why menopause happens?
Yeah. So essentially, all of the eggs in the ovary have kind of died off. It's a process biologically called atresia. And so we're born with millions of eggs in our ovaries. And once a month, once we go through puberty, we release an egg as ovulation. And then once we start to go through perimenopause and menopause, or really kind of ever since they start, they begin to slowly kind of die off. And so those millions are reduced to thousands to hundreds until really there's not much anything left.
So we talk about menopause and perimenopause in the reproductive sense, but it's a much bigger picture than that. Can you tell us about some of the symptoms?
Yeah. So estrogen receptors are in all parts of our body from head to toe. And so women experience symptoms in all parts of their bodies. And I think this is one of the biggest points I want to bring up today, because I think a lot of women and clinicians don't necessarily always recognize the connection of all of those symptoms to perimenopause and menopause. Commonly, we hear about hot flashes, night sweats. That's what we see depicted in the media. That's what I think a lot of people feel more comfortable talking about because maybe it's not so intimate. But we also see mood changes, sleep changes, dry skin, dry hair, vaginal dryness, pain with sex for the first time, lots of changes from head to toe, even musculoskeletal changes where bone density really starts to show up in weak bones and easier fractures. We start to see changes in strength. People talk about frozen shoulder. Really, the list could go on and on. There are so many symptoms.
And are those symptoms the same for people who are starting to experience perimenopause, the predecessor to menopause?
Yeah. So I tell a lot of people kind of think through your cycle. If you're not on some sort of hormonal birth control or something that's suppressing your cycle, or if you haven't had a hysterectomy and you can kind of follow what's happening from month to month, you'll start to notice symptoms starting the week before your period, because this is where we see estrogen levels decline, progesterone levels decline. And oftentimes women will start having sort of these PMS symptoms. They'll have mood changes, right? Lots of us know about those. We also see people will start to have migraines or heart palpitations or those sorts of symptoms, or vaginal dryness or pain really just that week before their period. And they might not even notice it, because then the rest of the month they're feeling fine. And then you fast forward 5 years and more of that month is feeling that way. And we're spending more of our cycle in that premenstrual period of things. And so those symptoms become more prominent until you can't really ignore them.
When you're in that perimenopause period, the point leading up to menopause, can you be experiencing those symptoms but still be having regular periods in terms of timing?
Absolutely. Yeah, you can still have regular periods. You're still ovulating, so you still go through the entire cycle, but you're having wider fluctuations. And so how I explain it to my patients is that when you have those estrogen drops or those progesterone drops, you're dropping a little bit lower. And so you might start experiencing symptoms that you didn't 5 or 10 years before.
Okay. What about testing for this? Do we just have to kind of anecdotally pay attention to these symptoms, or can this be something that we can actually get a lab test for?
Unfortunately, testing is fraught with difficulty, because if you think about those hormonal changes fluctuating up and down, your results might be different today as they are tomorrow. I kind of liken it to puberty. When we see a 12 or 13-year-old start to increase in their height and get acne or hair growth, and their voice changes, we don't really need a test to confirm that they're going through puberty. So if we know the age ranges and we know the symptoms, then we can usually diagnose perimenopause without really doing the test that can be kind of misleading anyway.
Okay. I want to remind our audience that we are talking about perimenopause, the period leading up to menopause, and then also menopause, the period in a woman's life where periods are no longer happening, ovulation is not happening. If you want to be a part of this conversation, you can give us a call at 866-578-0903. You can also send us an email at soi@ideastream.org if you're interested in sharing your experience or possibly asking a question of either of our panel members. And I'll bring in our panel member, Julianne, now, who is a patient of Dr. Pope's. Julianne, what was it that first made you think you might be having something different happening in your body?
Well, the precursor to this is my husband had passed away, and couple years later, I was having these fluctuations of mood swings, going from laughing about something to crying, looking at puppy dogs, and then being angry. And it would be pretty consistent in these changes. And so initially, they put me on an antidepressant, which I've realized quickly wasn't solving my issue, my problem, because I could feel different. I did not feel myself. And at one point, I was very, very nervous about doing hormone replacement therapy. But when I had the discussion with another doctor, she put me on a really mild dose, a really low dose. And I started feeling better. And so as time progressed, I'm like, let's try having another discussion about this and increasing the dosage. And that's when I met Dr. Pope, and we started, working with those dosages and increasing it. And I am living my best life. Like I call this my happy patch. I am grateful that I had the discussion with my doctor, that it's not all about doing research on social media. It really is a discussion with your doctor and knowing all your opportunities or, what's available.
And Julianne, you said your primary symptom was related to mood. Did you have the other symptoms that we talked about?
I did not have the night sweats or any of the other symptoms. It was definitely the mood swings and not feeling myself. Like I knew at my core that this isn't normal. This is not how one should feel. And like sitting watching TV with my family and then just start crying. Like, that's just crazy. So I needed to do something, and it was a discussion.
We got an email now from Barb. Barb writes in, great topic today. As I was listening before I logged on to email, I did not know that perimenopause could start 10 years before actual menopause. That explains why I was having hot flashes starting at age 42, but still having menstrual cycles. Not too many other annoying issues with perimenopause. Hungry, yes. Great libido, yes. Good hormone surges. Her final menstrual cycle was the summer of 2010 when she was 53. Barb, thank you for sharing that. And Dr. Pope, I'll ask you, is that something that you see often in your patients, that they are still having continuing menstrual cycles that are regular in terms of every 26 days, every 28 days, whatever they're used to before these things start to come on?
Yeah, I think that we're still trying to catch up with science. We are decades behind for women's health research, unfortunately. And for a long time, we have been able to show the clearest signs of when a period starts. That's very obvious to us, or when periods start to become irregular, that things are changing. But I think we are starting to pick up the fact that these changes are happening earlier than that. And that even when you're still having a regular cycle, you're still having the effects of perimenopause, which will eventually become menopause. And so, yes.
Now, I'll bring up this topic because, and this is a question that I've asked you a couple times now, because personally for myself, I'm 40 years old. A couple years ago, I had asked my own OBGYN, who's retired now, I said, I'm in this age cycle where perimenopause starts to be something I should be thinking about. My periods are still regular. And he said, you're regular, your periods are regular, that's fine. And I said, okay. And that kind of shut down the conversation. Yeah. So Julianne, I want to ask you, Naomi Watts thought there was this code of silence speaking about this, but you spoke to your doctor. So did you feel that way? Did you feel that there was a taboo around this topic to bring it up, or that it was shut down in any way?
To be quite frank, I didn't care because it was my health and I didn't feel right. And I encourage women, like, if you don't feel like yourself, have the conversation with your physician. It's so important. And I have to say, I'm living my best life now. I really am so grateful. I'm in a great place with my hormone replacement. I'm at a great dose. So I really encourage, it's so important, regardless, to do your research and to look and then have the conversation. Be prepared with questions.
Now, we talked about this lifting of the black box warning from the FDA. That black box warning was put in place in 2002.
Yeah.
Now it's 2025. That's 23 years.
Yeah.
Do you have any kind of idea, Dr. Pope, why this has just been lifted after consistent urging from doctors to say that we actually don't really think that's what's happening here?
Yeah, it's an interesting thing. So vaginal estrogen has never been linked with the health outcomes that the black box warning were warning about. And so that label never should have been there. And there's been a lot of advocacy for years to try to get that label removed. And most of the advocacy was around that. For systemic estrogen, for hormone therapy, we do see some increases in risks of blood clots, stroke, and heart attack. We can't completely deny that. But the risk is not as drastic as we thought from that 2002 Women's Health Initiative study that came out. And there are nuances. The risks are lowest for women who start hormone therapy in the first 10 years of menopause. And the risks start to go up after 10 years or after age 60. And so for years, there's been advocacy around changing the label, removing it from vaginal estrogen especially. And now I think that change has happened, honestly, because there are some very powerful voices on social media, which has urged these changes to happen. I think we have a generation of women who are demanding change and getting involved and advocating for themselves, and even celebrities who are going through menopause themselves or have partners who are going through menopause and making big waves in this space. So I don't know if it just took all of that in the pressure cooker to kind of make that change, or have some ears who are ready to hear those advocacies. It's been going on for a long time, so I'm grateful to see the change.
We have a call now from Stephanie in Seville. Stephanie, welcome to the Sound of Ideas. Go ahead.
Hi, my name's Stephanie. I'm calling from Seville, Ohio. When I was 32, I had a stroke, and I was on birth control at the time. My neurologist told me, don't even touch estrogen. Don't even go near hormone replacement. My OBGYN, when I started to get into menopause, was like, well, we can do this cream, and I'm very leery of it because I don't want to go through another stroke. I have no family history because I'm adopted. So my primary care doctor is like, even though the black box warning has been removed, she's not comfortable putting me on any type of hormone replacement. And I'm right in the middle of it. I'm 56 now. I have the hot flashes where it feels like I'm being cooked in a microwave, the night sweats. So I was just curious what the doctor felt about, someone with a history of stroke. Should they avoid any type of hormone, or is there anything that's changed since 2002 when I had my stroke? Or, I'm just kind of confused because I'm getting different advice from different doctors.
Yeah, sure. And she brings up a really good point, is that despite the removal of the black box warning, these things are still individualized, and you still want to have someone who's looking through your complete medical history, evaluating you physically in front of you to help you make those decisions. So what Stephanie describes is a provoked embolism. So she had a blood clot because she was on something that also put her at higher risk for a blood clot already, birth control pills. And so it does not mean that she necessarily has an increased risk if she's not on something. And so there would be people who would hesitate, and should be a careful discussion about the risks of being on systemic hormone therapy, which would help with the hot flashes and all those other changes. But for the vaginal cream that she mentioned, we don't see associations of risks of blood clots with vaginal estrogen, which is really only used for vaginal changes, urinary tract infection prevention, and to help with any pain with intercourse. It's not going to help with hot flashes or mood changes or sleep. And so they are two different treatments, but the vaginal cream for sure would be fine with somebody with similar background. But for the systemic estrogen, that would be a careful calculation of risk and sort of discussion, a shared making decision with your healthcare provider.
Stephanie from Seville, thank you very much for sharing your question with us. We have an email now from Chris. Chris writes, very glad you're addressing this. The problem with menopause care is not so much the labeling of hormone treatments, but the fact that OBGYNs refuse to treat it adequately. Chris says, I was having symptoms except for hot flashes, but still having periods. My OB told me she wouldn't address these issues because I was still making estrogen. So I waited and suffered and finally went to a functional medicine practice. Functional people often won't take insurance and it's expensive, but at least I got treatment finally. They did extensive blood work and put me on hormone replacement therapy, also referred to as HRT. Chris says, however, it's outrageous that mainstream OBs won't treat these symptoms, and getting care from a functional practice is basically menopause care for the privileged, which is something that we did come across in terms of researching this topic, is that it's difficult to get in, it's difficult to be seen. Julian, can you talk to us about what it was, your relationship like with your previous doctor, that made you feel so comfortable and made you be able to get the access to the care?
Absolutely. With my previous doctor, I said, you're my girlfriend. Like, I'm going to tell you everything. And when I was looking for a new gynecologist, that was exactly what I said to Dr. Pope when I went in for my exam. I said, I'm going to treat you like my girlfriend. I'm going to tell you everything. And I think that was the best way of handling it. Like, this is your health. And so I felt very comfortable in saying, these are my issues. How do I deal with this? What do I do? And I think it's so important to have that relationship. Treat your OB like your girlfriend. It made such a difference for me, because if I was holding back, she didn't get the full picture.
Mm-hmm. Like many things, if we're not open, we can't get what we need. But it can be difficult to be open, which is definitely a challenge. I want to remind people we're talking about perimenopause and menopause. If you have a comment or a question, you can call us at 866-578-0903. And you can also email us at soi@ideastream.org. We have a call now from Melissa in Canton. Melissa, welcome to The Sound of Ideas. Go ahead.
Hi. I was calling mostly to say I had a slightly different experience. Periods were a nightmare for me, and the fluctuation in those hormones were just outrageous. And when I hit menopause, which was actually in my early 40s, it was as if this wonderful light switch had switched off. And all of a sudden, I didn't have the mood swings. I didn't have the bloating and the pain. And when my doctor recommended hormone replacement therapy, my response was, you got to be kidding me. I didn't like it when I produced it. Why would I want it from you? Have you ever found that to happen with another patient, Dr. Pope?
Yeah, for sure. And I actually would love to address both your and Chris's comments because I think it really is important to see your gynecologist just for those reasons. You might have bleeding issues that they can help you with and help to navigate that. But there also has been this lapse of time where OBGYNs and other physicians were taught really to stay away from estrogen because everyone was nervous for the health outcomes like heart attack, stroke, breast cancer. And so in 2002, when that study came out scaring everybody off of estrogen, there was this huge span of time where people were not really being taught how to manage menopause. And then I'd say about a decade after that, people were being taught use the lowest dose for the shortest period of time. And then, now things have started to change. And what I think your point is so important that really everybody's experience is different. And it's not black and white. It's not that estrogen is going to solve all of your problems, right? You still may need some other health management, but having those options, having someone who can help you navigate them, whether that's because you need a hysterectomy because of bleeding and then you're doing fine and you just need that supportive care every year to check in and see if symptoms come up, or if you really need something even before going through menopause. That's why it's so important to see your physician for your one-on-one care. And yes, I have had patients like that who are so happy once they've hit menopause, and it's all about how, unfortunately, we've framed menopause as being negative, and really it can be very positive time for women.
I think just for me, it's just the confusion about it, the
Right.
lack of information. Tracy Ellis Ross says she feels her most sexy because she's not being ruled by those hormones that were fluctuating at different times in her life. So thank you very much, Melissa, for calling in with that, and Dr. Pope for your response there. Quick follow-up on that. Is menopause experienced differently for people who have hysterectomies? And maybe, Julianne, you can speak to this, because I know that's a different situation for a patient.
Do you want to start?
Sure. So I actually had issues with bleeding, and I had put off, Dr. Pope had suggested a hysterectomy, and I was like, no, I'm fine. And so we tried different things. The bleeding was getting bad, and I was on HRT prior to that. I'm still on, I had a hysterectomy, a month ago?
Yeah, like 2 months ago.
Very recently.
Recently. And again, I'm still on estradiol. I feel amazing.
Yeah.
I mean, the hysterectomy was because of the bleeding, but the HRT definitely was helpful in managing the emotions and the fluctuations. Before my hysterectomy, I was living my best life. Post hysterectomy, I'm living my best life.
Okay, and it's still very soon, so it's not necessarily a situation where you're thinking, I wish I would have done this sooner.
No, I mean, I think it was my choice, but Dr. Pope was, we had the discussion, and she's like, when you're ready, when it's time, and it was time.
Yeah. So I guess to go back to the first question, when someone has a hysterectomy, we typically leave the ovaries. So unless you are having a problem with your ovaries or you have ovarian cancer or something like that. And so if a woman has a hysterectomy, the removal of the uterus, and they keep their ovaries, they'll still go through menopause the same way, but they won't necessarily have those bleeding changes or the stopping of their periods to know, oh, okay, I'm officially menopausal now. But the symptoms otherwise would be the same. Once a woman has had a hysterectomy, if she's on estrogen therapy, she doesn't need to have progesterone therapy because that's really to help with protecting the uterus from the estrogen. But a lot of women do benefit from the progesterone. It helps them to feel calm and it can help them with sleep. So sometimes we have patients who don't need the progesterone but still request it and benefit from it.
Okay. We'll be continuing this conversation. Of course, Dr. Pope and Julianne, you'll be staying with us. And we are continuing to take calls when we talk about perimenopause and menopause. You can give us a call at 578-0903. You can also email us at soi@ideastream.org. We know we have several callers on the line waiting to have a conversation. Beth in Shaker Heights will be talking to you right after the break, so hang on with us, okay? We'll be back in just a moment. This is The Sound of Ideas. I'm Stephanie Haney. You're with The Sound of Ideas from IdeaStream Public Media. I'm Stephanie Haney. Thank you very much for staying with us. We've been talking about how women navigate the normal but often undiscussed life stages of menopause and perimenopause with doctors and a patient. Staying with me in studio is Dr. Rachel Pope, OBGYN and Chief of Female Sexual Health for University Hospitals. We also have her patient Julianne Sutton with us. We'll bring in another guest in just a moment, but I want to get to a caller who has been waiting to ask a question. So we have Beth from Shaker Heights calling in. Beth, welcome to The Sound of Ideas. Go ahead.
Yeah, I have a diagnosis of factor V Leiden, and I wanted to try hormone replacement therapy. Is that even an option to do safely?
It's a hard call because it does mean you have an increased risk of clotting, so blood clot or a clot in your lungs and stroke, unfortunately. So those are very scary things. I would encourage you to see a physician and or an advanced practice provider who specializes in menopause and have a conversation. Transdermal estrogen, an estrogen patch or gel, is the lowest risk of blood clotting. So sometimes for women who really feel like their symptoms are worth the risk, can use the safest type of estrogen to try to get relief. But we also have some great non-hormonal treatments now. They've come out in the last 5 years or fewer. So there are more options. So it'd be worth a conversation just to see, for your specific symptoms, is it worth the risk, or would you rather try a non-hormonal first?
Thank you very much for that answer, Dr. Pope, and Beth for being patient so that we could get your call in there. Now we'll bring in our third guest here to help us talk more about the mental and emotional side of menopause is Dr. Erica Kelly, a clinical psychologist with University Hospitals and an associate professor in the Department of Reproductive Biology at the Case Western Reserve University School of Medicine. Dr. Kelly, thank you so much for calling in.
Thank you so much for having me. I'm happy to be part of this conversation.
And I want to remind our audience as we continue this conversation about menopause and perimenopause that if you would like to call in with a question or a comment, that number is 866-578-0903. You can also send us an email at soi@ideastream.org, or you can send us a message on Instagram at The Sound of Ideas. Dr. Kelly, can you tell us about your work in the perimenopause and menopause space so we can sort of set the stage about your expertise here?
Sure. So, as you probably know and have discussed already, there's a lot of different symptoms that may be experienced or changes that can be experienced in the menopause transition, including psychological and relationship and social changes. And so, I'm lucky to be part of an interdisciplinary team. I work with Dr. Pope, for example, on our female sexual medicine team. And so, a lot of the symptoms that can come up can be best managed in an interdisciplinary manner, meaning you may see more than one specialist or provider who can work together to really focus on holistic care. So I'm happy to be part of the sexual medicine clinic. I also work in our OB/GYN department, so I get referrals within that clinic and see women with a variety of experiences, distress, symptoms in the context of menopause. And I also do research in the space of menopause as well.
Erica, I want to ask you about a recent article that you published, and it included the statistic that menopause-related health care was included in fewer than 1/3 of OBGYN residency training programs. So can you talk to us a little bit about the need to seek out someone who specializes in menopause and how not every doctor may have the necessary knowledge?
Yeah, of course. I think there's a lot of fear that is in the space right now in thinking about menopause and appropriate treatment for management of symptoms. And one of the things I like to think about is if I go on social media as a provider with experience and education in menopause, I'm overwhelmed by the information that's on there and the differences in information you might hear from one person versus the other. So I just think about like in the general public and community, that would be really, really hard to follow. And you'd want to make sure that you are seeing a healthcare provider who does actually have adequate training and experience in this space. I know for myself, I did not get exposure to menopause related health and well-being until fellowship. So that's after completing graduate level training, after getting my PhD, after internship. And it was a very rare training experience to have. In fact, I know only a handful of other colleagues in psychology really who have had this training. So it's really, really important to see a provider who specializes in this space. And I think to grow our understanding of menopause health and well-being, we need, to increase advocacy. We need to increase conversations about it so that we can really emphasize the need for medical training in this area.
How important was that to you, Julianne, when you were searching for a new OBGYN?
It was very important in terms of, like, I didn't want to find, I had already started on that low dose, and I didn't want to find a doctor who was going to say, no, I don't do that. I did do a lot of research in terms of looking on, not online, but through the hospital website to find a physician that was available. And it just happened that I happened upon Dr. Pope, and the first discussion was about, I'm on this, I want to stay on this. And she was all, that's great, let's talk about it. And, again, I'm in a great place. And I think it's, because of the discussions I had with my physician. Knowing your risk and having those discussions with your physician about those risks are important.
I'll ask you, Dr. Pope.
Sure.
You're an OBGYN. Why aren't primary care doctors specializing in perimenopause and menopause, given the wide range of symptoms? I know you're not a primary care doctor.
That's okay. I'm married to one.
Okay, great.
I think there's so much that they have to juggle. There's so much that they have to keep up to date on. And of course, it's their job. But also, menopause does get a little complicated, right? So if you start someone on hormones and then they have bleeding issues, it gets to be tricky to then manage if you're also trying to help them with their diabetes and screening for cancer and all of these other things. So I think that there's just a lot. So I usually encourage people, if they don't want to specialize in menopause in their primary care practice, find a menopause provider who they can buddy with, that they can refer to. We've got such a wealth of opportunities here in Northeast Ohio. I'd say we have a midlife women's center at university hospitals. We have the female sexual division at university hospitals and the Urology Institute. That's where I work. And so even in our department in OBGYN, we've had 3 past presidents of the Menopause Society. So while it is very true that a lot of OBGYNs and primary care physicians haven't got the training that they really need to manage this, we've got a wealth of really well-trained people in Northeast Ohio at UH. Of course, in primary care, I think it's just a challenge to do everything. And there are some fantastic primary care physicians who have decided this is important for them, and they see this segment of the population. Well, most primary care physicians do see women, right? Adult women. And so if they feel comfortable, then they can get into it. But there is a lot to keep up with. We go to yearly conferences to keep up to date. There's a lot of research that comes out on a regular basis that we all have to keep up with. So if you are managing the care of everything else for a person, it could be a lot to keep up with. And, I definitely appreciate that.
Okay. We have an email now from Christy. Christy says, I hope more women can find an educated provider to help. I am now taking bioidentical hormones and it literally saved my life. We need to continue the conversation that perimenopause and menopause are so much more than hot flashes. If one version of hormone replacement therapy doesn't work, don't give up. And Christy says, thank you for platforming this. Thank you for that comment, Christy. And that's something that we've talked about a couple times today with different people asking questions and comments about the different options that are available. I'll also share an email now from Ted. Ted, subject line of the email says, comment from a husband. I just wanted to thank you for covering the subject of perimenopause and menopause today on NPR. I had never even heard of perimenopause before. I am 45 years old and my wife is 42. Today's discussion has helped educate me, which results in a greater understanding of what my wife will be experiencing in the future. The cone of silence you talked about definitely extends to men. We don't begin to understand all of the changes that a woman goes through, and I'm sure a lot of women don't discuss this with their husbands because they know we just won't understand. With this knowledge, I hope to be someone my wife can rely on to talk to openly about these things so she doesn't have to go through it alone. Thank you for talking about this in a public space. Ted, thank you very much for sharing that comment And thank you to our patient and our two medical professionals here for enabling us to have this conversation. Dr. Kelly, can you talk to us about some of the mental and emotional symptoms of perimenopause and menopause?
Sure. So, for some individuals who have a past history of depression, they're going to be at greater risk for increased depression symptoms during menopause transition or during perimenopause. Now, that's not a universal risk. So, I want to be really clear in that for some individuals, they may even notice an increased or improved quality of life with menopause. So, I don't want to send the message that it's like a doomsday thing. But as Dr. Pope mentioned, thinking about individual level risk factors, those individuals with a past history of depression, especially if there was postpartum depression or premenstrual dysphoric disorder, which are depressive symptoms that show up within the few days or week prior to menstrual cycle, those are individuals who are going to be at greater risk for depression symptoms with perimenopause. And that's multiple different factors. We like to look at it from a biopsychosocial perspective. One of the factors may be the hormonal component, that with the increased hormonal fluctuations during perimenopause, some women are just more susceptible to mood changes with those fluctuations. The other thing that we sometimes see is increased anxiety. That's a little bit less common than the depression symptoms. Some of this is also affected by the physical symptoms experienced with menopause. So, if someone is having a lot of night sweats and hot flashes, you can imagine where sleep would get really disrupted. And sleep is a primary risk factor for mental health symptoms. So, if your sleep isn't going well, then you may be a little bit more vulnerable to anxiety or mood symptoms. We also see just the general distress impact. If you're going through all of these symptoms, and especially if you don't know what's going on, right? That's really scary. That's really scary to be going through these experiences. And that can be something that can increase the anxiety level. But again, I don't want to send the message that that's a universal experience, but understanding your own individual level risk factors. Another thing that's important to consider is attitudes towards menopause. So we actually see a lot of research that shows that more negative attitudes towards menopause is associated with more severe symptoms. So that's, a relevant factor as well.
That's a real chicken and an egg question there, I would have to assume. Which
Yes.
one causes the other? We are going to take a call now from Layla in Cleveland. Layla, go ahead. Welcome to the Sound of Ideas.
Hi, thanks for having me. I wanted to talk about my perimenopausal symptoms. I had a hysterectomy 2 years ago due to fibroids, but I also have an overactive bladder, so I receive Botox in my bladder like every 3 to 4 months. But I wanted to ask a question about like the sleeping, teeth grinding, the mood changes, the night sweats. I don't think my husband even understands anything that I'm going through, but it's a lot, from day to day. And I wake up in the morning and I'm like, my teeth are hurting, I'm hot, I'm waking up in the middle of the night. So I just have a lot of things going on with this perimenopausal. I think I'm going through some things like losing my mind almost.
I hear that from my patients all the time. They feel like they are not themselves. They feel like they're crazy, or they feel like, they just don't feel right. And I think it's exactly like Layla said, it's multiple symptoms that may not seem to be connected, but actually are. And if we think about it, any time in our life where our sleep was disrupted, how awful you feel the next day. So if you imagine that poor Layla, you're experiencing poor sleep every day, then you're going to feel pretty crappy every day. And so I think getting help to see what's the underlying cause here. Is this because of perimenopause? It sounds like it to me, but there might also be some added elements, right? I'm not a dentist. I would definitely encourage you to get help with the teeth grinding, but it might be associated with stress. We see that for sure. A lot of underlying things then cause the next problem. And so if you can treat the first issue of perimenopause, you might see that everything actually improves.
Julianne, when you talked with our producer Rachel ahead of the show, you talked about how something like a pencil being out of place might set you off. And aside from that feeling of anger that you were having, can you tell us how you were feeling to be reacting so differently to things that had previously not bothered you? Was it scary?
It was unnerving. I couldn't understand like why something so small would set me off. And again, I go back to the puppies on TV. I'm like, why am I crying over this? And it and Layla had said about the teeth grinding. I'm like, wait a second, I had that as well. And there were not sleep issues, but it's interesting to hear people as they're talking about their symptoms. I'm like, did I have that as well? But the main thing for me was that mood swing of something being out of place or somebody saying the wrong thing to me. And while, I wouldn't outwardly be mean but I knew it wasn't right. And I knew I wasn't feeling myself. I can't even stress how much that meant to me, that I felt off and not knowing what it was that really made me try to figure it out and having those discussions. It wasn't antidepressants, like I'm not on that. Like it was hormones from the beginning. And it was the discussion that helped me navigate that.
Dr. Kelly, we had talked earlier about how Julianne, and she just mentioned it there, was prescribed antidepressants, which ended up not being what she needed. Can you talk about some of the therapies that are available to people to help them feel a little less maddened in this time?
Yeah, certainly. I always say validation, I think of as a very core human need. So just hearing from a provider that your experience is valid, your distress is valid, your symptoms are happening, right? Like that is a real experience. So I think that alone is very, very powerful. And having an understanding of what's going on in your body is really, really important, again, to get that specialist who can validate the experience and help you figure out what is the best management strategy for you. The good news is we do have a lot of different options. So one of the evidence-based or research-supported psychotherapies that exists is something called cognitive behavior therapy for vasomotor symptoms. So this is a cognitive behavior therapy that focuses on the impact of night sweats and hot flashes. And we use cognitive strategies. So things like we mentioned the attitude towards menopause. We think about how does your thinking affect your symptoms? How do your behaviors, how does your lifestyle affect potential symptoms? So part of that is looking at like reducing stress, it's improving sleep. So that is an option that someone could look into. A lot of times we think about, trying therapy out for about 8 sessions or so, and you should be able to see an effect by then. And sometimes you need a combination of different approaches. But again, the good news is we do have available options. It really just depends on what symptoms somebody might be experiencing. We talked a little bit about, I think it was Layla that was saying, in the context of the relationship, right? Like if you feel like you're going crazy and your partner doesn't understand, and there can be a lot of relationship stress, we also have therapies to address the relationship components. Interpersonal therapy and cognitive behavior therapy are also 2 options that are evidence-based. So again, it kind of depends on the specific symptoms, but we do have some good research-based options.
So we've talked a lot about what actually happens in menopause, and we've talked about all of the physical symptoms that people experience. Let's talk about the sexuality piece of it for a moment. Now, Dr. Pope, you helped author a book called Sex in Your 60s.
Yeah.
What happens physically to women's bodies during this time when it comes to sexual activity?
Yeah. So one aspect of that book is I co-authored it with our division of female sexual medicine. So Dr. Kelly, Dr. Kingsburg, Anna Myers, Jean Marino, and Karen Connor were all co-authors. And the reason I mention them all specifically, not only because I love them all, they're amazing human beings, but because they are experts in their own fields. And it's an interdisciplinary approach to helping women through sexual function. So they are psychologists, they are clinicians, and they're physical therapists. So specifically pelvic floor physical therapists. So we start to see changes where women experience pain for the first time because they might have vaginal dryness. They might have changes to their anatomy that happen with menopause that cause more pain. And they might experience decreased libido, not only because things hurt now, but also because with the decreasing testosterone levels, their desire decreases. We see difficulty with orgasm, whether it's they can't achieve orgasm or it takes longer or it's just not as pleasurable as it used to be. So it does really take the whole team of specialists to be able to help. But the good news is there's treatment and women can get feeling way better and improve that part of their quality of life.
Julianne, I know dating was a piece of the puzzle for you when you were going through perimenopause and menopause and the things that you've been through. Are you comfortable sharing anything about that with us?
I'm not dating anyone currently. So I think when the opportunity presented itself, the sex was amazing. And I attribute that to hormone, but I'm kind of at a loss, like how to go further
Do you
with.
mind if I interject?
Of course.
I mean, I think also for what I see for women, not just Julianne, is that at this time of their life, they have gained so much life experience that they can advocate for what they want and not feel like there's all this inhibition that's put on women, especially, sort of in earlier years. Would you
Right.
agree?
Well, yes, and I think to speaking of my girlfriend, when those times did happen, I did say to you, like, this is the best I've felt, like, sexually, as a female, as a woman. Like, I had my most positive experiences during that time. And not that, I feel wonderful now. Like, I'm very confident in the way I present myself, and I think it's just I don't even know what the word is I want to use, but
Empowered?
empowered. I think that's a great word.
We only have a few minutes left, so I want to try to get to a couple things really quickly here. Dr. Kelly, I'll ask you, can you talk to us about the mental side effect when it comes to people dealing with menopause from your experience sexually?
Oh, sure. So definitely can increase interpersonal distress, so partner-related distress in the relationship. Sometimes when libido goes down, as Dr. Pope was saying, the partner might feel rejected or feel like they're no longer attractive, and so it can lead to some miscommunication in the relationship in that sense. We also see if there's physical changes in the body that might contribute to lower body esteem or body image. That might affect the experience of sexuality, and it kind of turns into a bit of a feedback cycle. Unfortunately, but again, as Dr. Pope said, thankfully we have management options. And one of the things I just wanted to throw out there on this topic is there's a series of studies that are coming out that are showing the positive effect of masturbation or self-stimulation for menopause symptom relief and increased quality of life, which I think touches on this empowerment perspective, and self-exploration and kind of knowing your own body can be really, really empowering.
As we're talking about this, I would like to clear up one medical question. Can you get pregnant during menopause?
Yeah, kind of. So not during menopause when your periods have stopped, but during perimenopause. And it can be really confusing for women and their clinicians, whether they are right on the brink of menopause or still in perimenopause. So if you are still ovulating, if you're still having periods and you still have a uterus, then you could still become pregnant. But once you've gone 12 months without a period, then the chances are very low. Although we do say you should still stay on contraception for that full year after your last period to make sure there are no chances of accidental pregnancy. So it's mostly not, but it's still possible.
And Erica, as we kind of start to wrap things up here, what advice would you give to people who are looking for resources to help them navigate the mental side of perimenopause and menopause?
Yeah, I think starting with the Menopause Society and also looking at organizations like Let's Talk Menopause and National Menopause Foundation, there's phenomenal community groups and support groups. And so I think being able to have those connections can be really helpful and empowering. I think sometimes it just makes a difference to hear from, another woman going through experience and not just a healthcare provider. So knowing that there's a big community and there's a lot of hope, I think is important to hold on to.
Dr. Pope, you run a menopause retreat. So tell us about that.
Yes. So with Anna Myers and Jean Marino, we started the Menopause Retreat. It's outside of my full-time job. It's a kind of a weekend side hobby, I would say, mostly because we kept getting invited by women that we knew to come to their homes and answer questions about menopause. And we realized that there was a need for this. And I think especially nowadays, while so many of us are looking at social media for information, and, I try to post good information there too, what we're really lacking is community. And so many women tell us, my mom didn't really talk about menopause because it felt sort of stigmatized, or she didn't get help through it, so I didn't know where to turn for help. So being able to be in a format together with peers who are either going through it or have gone through it and talk about what's helping them and reach out and make those real, in real life connections is just so valuable these days.
We have another listener email that I'll share as we wrap things up today. To Julianne, appreciate your openness and willingness to share your story for all of us on The Sound of Ideas here today. So thank you so much for that. That's from an audience member.
Thank you.
And that was Julianne Sutton, a patient of Dr. Pope. Thanks for being with us, Julianne.
Thank you. Glad to be here.
And Dr. Rachel Pope, OBGYN, the Chief of Female Sexual Health with University Hospitals. Thank you for your time.
Absolutely.
On the phone, Dr. Erica Kelly, a clinical psychologist with University Hospitals and associate professor in the Department of Reproductive Biology at Case Western Reserve University School of Medicine. Thank you very much for your time.
Thank you.
To get the last word on today's topic, you can email us at soi@ideastream.org. Tomorrow on The Sound of Ideas, we'll learn about a group that confronts and demystifies the stigma around death, and we'll meet the new head of the Port of Cleveland. Thanks for being with us here on The Sound of Ideas. Thanks for keeping the conversation going. I'm Stephanie Haney. We'll see you back here tomorrow.